So yes, it will be out of 30 questions. So Shelby has asked me, will the exam still be out of 30 questions? Yes, I'm not dropping it. I'm allowing both ways to be correct answers because that mathematically will help people the best. And quite frankly, it was the only thing that fouled up that question. Nearly everybody else got the other three things correct. So the vast majority of you will find that now to be a correct answer. Thanks for clarifying that, Shelby. Okay, so let's go ahead and dive into our information for today. We're going to be talking about children with neurodevelopmental disorders. So once again, anytime we're doing something in psych, pay attention to what the word is actually telling you. Sometimes you don't even have to, maybe you've never heard of it before, but the word itself will tell you what we're talking about. Clearly, this person has a neurological problem, so something's wrong with the brain, and a developmental problem, meaning that it happens to foul up their developmental trajectory. They aren't able to develop in the normal course of life like we would expect children to develop. So neurodevelopmental disorders are disorders that are going to hold somebody back to a degree because of something going on in their brain. So the common things that are talked about under this particular topic are intellectual disabilities, ADHD, and autism. And once again, I'm putting this kind of chart in front of you as a study tip because it's important for you to know that these are the three disorders that are under the category of neurodevelopmental disorders, and for you to be able to see how they're the same because they all have something to do with the brain that's preventing the same developmental trajectory as other children, but they're also very distinctly different from one another as well. So when you study, you'll want to make those contrasts. It's a good idea, even if you want to start doing it while you're listening to the presentation, to start putting the signs and symptoms and the treatments into the proper area of the table. And that way you're kind of studying as you go along and getting some of those fine-tuned ideas conveyed. So these are the three neurodevelopmental disorders we'll be talking about today. Also, I have a little tip. Under nursing interventions, because this is it's a childhood onset, meaning that these neurodevelopmental disorders nearly always happen. It's starting in childhood, and often people are born with the problem. And so if you want to make a change in somebody's home and make it better for children, who is it that has to change? So there's the little hint there, of course. Yeah, it's the parents, right? So if you want to make things better for the child, you need to address things with the parents and teach them how to do things differently than they may be doing it now in ways that will benefit the child. So that's kind of true for any pediatric issue. We teach the parents, and in so doing, that's how we treat the child. Okay, the second kind of big tip I want people to remember, and feel free to chime in as we have these discussions, because many of you will have personal experience with these three disorders that we're talking about today. Either you have somebody in your family who has one of these, maybe you have one of these particular things that you have been living with throughout life. They're very common, and so they're very relatable. And as you can imagine, if you're the parent of a child who perhaps has intellectual disability or autism or some other concerning problem, you're all over the internet, right? You're trying to find, what can I do to best benefit my child? You're trying to get services to help your child. You're doing everything you can possibly think of to help your child have the best possible outcome. And sometimes parents get so wrapped up in the disorder that they forget to enjoy the childhood. Children are a delight, and children with these challenges are also delightful children, and they bring a lot of joy to those around them. And so we always want to encourage parents to relax a little bit. Certainly we want to do the best we can for the children, but not be so wrapped up in the diagnosis that you can't just enjoy the child day to day as they learn, as they do fun, cute little things, as they have memorable experiences with the family. So giving permission to the parents to enjoy the child, enjoy this time with their child. it goes quickly for all of us who are parents. Childhood seems so busy at the time we're in it, but then they grow up and they're on their own and they're wonderful young people. But this is the fun time, and we don't want parents to miss out on that. So when we talk about childhood neurodevelopmental disorders overall, they're called disorders because something's wrong in a way that's definable and is in the DSM-5. What's the DSM-5? Yeah, it is essentially the dictionary for disorders. It is the manual that the physicians go to, and it's got all the disorders in it and the behaviors associated with each disorder. It's how the doctors make the diagnosis. And in order to fit into that category, then it has to be outside the normal experiences of people in such a way that it actually rises to the level of being a disorder. So it has to be that the child is not age appropriate, and they've deviated from cultural norms, and it's impairing their adaptive functionings in life. So it impairs what a child should be able to do in life. Can they, if they're 10 years old and they still can't dress themselves, they have an adaptive function problem. So that's what this means, is that this has to be outside the normal experiences for children. And we know that not all children are the same, and some are very energetic and some are very easygoing and some are a kind of intense children. But that doesn't necessarily mean they have a disorder. That just means they have personalities and that they are young people growing and learning. And we don't want to call things that are normal a problem. So it has to meet this criteria in order to actually get one of these diagnoses. The 3 neurodevelopment disorders we're going to focus on are intellectual disability, attention deficit hyperactivity disorder, ADHD, and autism. So let's start with the intellectual disability. So looking at that name, what is it telling you is going on, just by the name? Great. They have a learning disability, absolutely. They're intellectually not developing as well as they should be. And it's actually a profound one. You can have a learning disability, for example, like someone's dyslexic, where they're getting things mixed up in their reading. And that is an important challenge for people as well. But when we say intellectual disability, they not only can't learn, their actual intellectual development isn't on the right trajectory. So for example, Down syndrome children are often what we think of as kind of the template for this disorder, because they are simply not growing up and learning as much as they should by certain ages. And so they're having challenges with all intellectual abilities, not just a single, for example, reading disability. And so when you look at intellectual disabilities, the old name for that was mental retardation. Now, that was actually the name in the DSM-5 up until 2013. And they renamed it because, unfortunately, in popular literature and within the public, that term became stigmatized and took on a negative connotation. And we don't want our disorders to have negative connotations. But you can see that the term mental retardation describes exactly what intellectual disability describes. It means mentally or intellectually, they're slow, retarded. So initially, it was just describing the condition, but because it took on that negative connotation, it's no longer used. And instead, we call it intellectual disability. I want you to be aware of that in case you see that written in people's charts. Somebody is not being mean-spirited. If you're looking at old charts, that was the official term to use. And so we've just changed it because we don't want that negative connotation to go forward. But they are one and the same thing from the DSM-5 point of view. So general intellectual functioning can be measured by IQ tests, but it's more often today measured by your academic ability. The reason for that is IQ tests are fine, meaning that they did give us some idea about the person's intellect, but IQ tests are notorious for being culturally not able to cross cultures well. That if you are from a different culture and you take an IQ test that wasn't written for your culture, then you look like you don't know things, and it's really not about your intellect. They just don't mesh well. So to avoid that challenge, the use of IQ tests is maybe in the person's chart, but they're not heavily relied upon, and especially if it's not matching culturally. Instead, we're going to look at their academic ability. So in other words, are they a second grader intellectually? Are they a fifth grader intellectually? Are they a 10th grader intellectually? Where are they in the grade school system? That's a more universal language that doesn't carry the possibility of biases that are unwanted. Adaptive functioning refers to the person's ability to adapt to requirements of activities for daily living. So getting back to that idea of, can a child who's 5 years old pour a bowl of cereal and milk and feed themselves breakfast independently? Well, hopefully they can. Now, they might spill the cereal on the table, and there might be a few drops of milk around, and there's quite a bit of a cleanup, but they could do it. And that would be something that was normal and expected. So if you have a 15-year-old who still cannot successfully pour their own milk and cereal for breakfast, they clearly have an intellectual disability. And it shows that their adaptive functioning is behind the developmental curvature. Okay, so there's lots of reasons people can end up with an intellectual disability. Hereditary factor, again, Down syndrome being the common one that we kind of use. People can relate to that and understand what we're talking about. Most of us have people we've interacted with or have known somebody with this condition. And so I'll refer to it as kind of the template, but it's certainly not the only reason you can end up with this condition. There can be other hereditary factors that result in this. I have, one of my nieces has a child with a genetic disorder, a rare genetic disorder. They still haven't actually figured out what caused her challenges. And she's struggling with intellectual disability and some health problems, eyesight and those types of things. There can be challenges during the developmental phase. So perhaps something happens in embryo. The mother is exposed to, something, Zika or something, and it causes the child to be born with a smaller brain and intellectual disabilities. Pregnancy and prenatal factors. Were they exposed to something? Did they, in the past, you may be aware that we've sometimes given drugs for nausea for pregnant women, and that led to some challenges, some birth defects. So those are kinds of things that could affect. Under that category, fetal alcohol syndrome is a common cause for intellectual disabilities. That the mother drank or used other illicit drugs during pregnancy, and that's what caused the harm. General medical conditions that the child actually has, and other environmental influences that people may or may not be too aware of can lead to this challenge. So when we look at the child, then we want to assess for the intellectual functioning, their ability to reason, problem solve, plan, academically learn, and we want to look at their adaptive functions. Can they do what you should be able to do to take care of yourself in life? So those are the two areas we're going to look at. And this chart is a highlight chart. I want you to red flag it, do whatever you do to remember that when you study it, you need to know this chart well, because this is how the diagnosis is made. And it tells us as nurses what the child's abilities are, so we can try to capitalize on their abilities and help them with the things that they may be slow with. So there are 4 kinds of intellectual disability. There's mild, moderate, severe, and profound. Fortunately, most people have mild intellectual disability. About 85% of the cases are this way. And they have difficulty adapting in school, and eventually they're going to make it to the 6th grade level. Usually they're in their late teens before they develop 6th grade level intellectual ability, reading skills, managing money at a 6th grader level, doing those kinds of things. They're also going to have the social and adaptive functioning abilities of a 6th grader. So just type into the box, those of you that have been around sixth graders, you have had children who are sixth graders. What are some of the things that sixth graders can do specifically? Can they prepare a meal? Can they manage money? Can they get their, how much can they read? What are their math skills like? What are some things sixth graders can do? They can care for younger children with some support, right? If they are caring for younger children, they're going to be fine unless there's a big problem. Maybe the younger child falls and breaks their arm. Then the sixth grader would need an adult to help them solve that problem, right? Making simple meals, mac and cheese, toast, eggs, great. They're going to be able to do that. They're not going to be able to do the Thanksgiving dinner, bit complex, but they can do the simple stuff for sure. What about money? What can they do with money? Do they know, nickels, dimes, quarters, what things are? Spend it. I love it. That's true. They're very capable of spending their money. Exactly. And they can actually figure it out to a certain degree. When our daughters were young, we gave them a certain amount of money for back to school clothing. And we told them it had to fall under certain parameters. So, things like underwear and stuff were purchased, but then they could spend the other money the way they wanted to. And it was interesting because we started this when one of them was older and we let our sixth grader do it as well. And interestingly enough, she was great at it. She got a lot more clothes than her older sister at it because she was able to figure out, if I spend my money on less expensive clothes, I can have more. So she actually did a really great job with spending within the means. She understood money and she was capable of figuring it out to a degree. However, do you think they have enough insight and ability to get the paying of bills independently? Understanding that rent's going to come due and that the electricity might be more expensive in the winter and those kinds of things. That kind of more advanced understanding of finances or saving for a rainy day, those kinds of things probably would need more help. A sixth grader probably can't quite grasp that much about money management. So keep that in mind. A mild child with intellectual disabilities will grow up to be a sixth grade level person, late in teens or young adult years. So they're educatable, meaning we can send them to school and teach them to read and write and do math and the basic kinds of things. They're not going to do calculus, but they can do add, subtract, multiply, and divide, the basic things they need to do in life. This is good because when they get older, with support, they might be able to live independently. They would need somebody to help them solve significant challenges. The plumbing goes bad in the house. They may not be able to figure out how to get a plumber in there to help them. So they're going to need a close resource, but they might be able to be a little bit more independent, and they could have a vocational kind of job where it's the tasks they're expected to do are within the realms of a safer sixth grader, and they might be able to have that kind of job. Okay, so moderate is this person has poor awareness of needs of others, and they typically don't progress beyond a second grade level. So go ahead and type for me right now, any of you who have connections with second graders, tell me what they can do and what they can't do at a second grade level. And as that first statement starts, second graders can be sweet and they can be kind, but they don't really have a great awareness of others, meaning they might see that mom is sick, but they don't really have ability, is sick, but they don't really have ability to understand the implications of mom being sick. They might be sad for somebody, but they don't really have an overall understanding of what's going on. And they often miss social cues about somebody else when they're in the moment of wanting something themselves. That's typical of a second grader. So let's see, more messages below. Very good. Okay, so I just saw that my thing gave me some more things to see here. And so they're not very logical. It's true, they're not going to be able to have the same methodical process of figuring it out. I'm not going to hand my second grader, a couple of $100 and say, go get your school clothes and think it's in any way, even with some guidance, going to be successful. They're going to need a lot more holding of hand. But they can still do some very basic things. Again, like we said, prepare the cereal in the morning, heat up some leftovers in the microwave, get themselves dressed, and they can do the very basic skills. They can do some basic reading, some basic add and subtract kind of math. They're going to be able to do second grade level things. So, a moderate child, when they're in young adult, or late teen or young adult, they're going to get to the second grade level. That means when they were 10, they were not at second grade level, right? They were still advancing towards that. In the end, they might be able to have some vocational training and may be able to get unskilled labor that's something repetitive and they're very trainable to. You guys aren't on campus as often anymore now, so you may not have seen this, but we often have a partnership with an outreach program that brings children in with these intellectual disabilities and teaches them to vacuum the floor and to, clean the doorknobs and to clean the windows and do some basic jobs. And they can do it, but they don't stay on task unless the supervisor's there saying, remember, you've got to wipe this area, remember. They can do it over and over, but they have to be reminded and encouraged. And so they can do some pretty basic things under supervision that aren't going to be beyond a second grade level of comprehension, and they'll probably need help staying on task. Now, this is the other 10% of children with intellectual disability, which means that the majority of 95% are going to make it at least to this level. We then have severe and profound. Severe is about 3 or 4% of the remaining children. They have poor motor development and minimal speech, and they're unable to learn any academic skills and may not be able to talk. They can, it says may learn to talk. So over a long period of time, you can teach them some words and you can teach them some communication that is going to be pertinent to what goes on in their life. They're not going to be great conversationalists, for example. And they can be trained to elementary hygiene, meaning you can get them to figure out you need to come down when you get up in the morning, you go to the bathroom, you come down for breakfast, you take your dishes to the sink, you get your teeth brushed, you put your clothes on, maybe with some help. So they can get routines down of very simple things. And you can see that these children are much younger, right? They're going to be like a 4-year-old, a 3-year-old. And they're going to be that way all their life. And then the profound is minimal capacity. Profound means they are an infant for life. Now they're getting bigger, right? They may be 5'10", but the intellectual ability is that of an infant. So they need constant care. Now let me just point out to you in the comments station, it says that they need custodial care. Now, every once in a while, I have students think that means they can do custodial care. The children who can do custodial care are moderate and mild people, meaning they could be taught to do cleaning the building with supervision. What it means here is custodial care means that you can never leave this person alone. They are an infant. Do parents ever leave infants alone? Never. They might be sleeping in the other room, but even then you probably you check on them frequently, or you have a monitor so you can hear them when they wake up. That's the kind of care this person's going to need all of their life. Any questions on the severity scale for intellectual disabilities before we go on to what we do to help the parents? Okay, so this is a very important scale, and make sure that you have familiarized yourself with it. So nursing interventions, risk for injury. So remember that when I talked about taking exams, especially exams about psychiatric questions, the ABCs are the priority for a medical surgical problem. And for mental health problems, it's safety and basic needs. So keeping the person safe is the first priority. Making sure that they don't hurt themselves. So let's go back to that child who is let's suppose our intellectual age of this child, even though they're 20 years old, their intellectual age is that of a 2-year-old. Type into the chat box some of the things you would need to do in the home to keep this person safe. Choking hazards, right. So you don't want things on the floor because they're going to be just like the normal 2-year-old. They may be 20, but they're going to put things in their mouth. They're going to pick up whatever's left on the floor, put it in their mouth. Keep them away from pools and tubs. They're a drowning risk, absolutely. Electrical cords, right? Those are important too. Secure things to the wall, absolutely. They're going to pull things down on themselves. And now because they're taller, that's even more likely to happen. So very important. So can you see that when we talk about safety for children with intellectual disability, it's their developmental age that determines what we teach the parent and what we as nurses do for them. If they are intellectually a 4-year-old, we do everything we would have done for a 4-year-old, irregardless of their actual age. The same with self-care deficits. If they are a 4-year-old, they might be able to get themselves dressed, but somebody's going to need to do the laundry. And if we want them to wear things that match, we may want to lay out what we want them to wear. Those kinds of things. We need to be very straightforward in our communication with them, working one-on-one with them, giving them concrete explanations that are simple. Concrete means that children take things at face value, right? They don't realize that words can have multiple meanings. So be clear when you're talking to them. Again, it's all about what their actual intellectual age is, not what their actual chronological age is. So if this is somebody who's developed to a 6th grade level, even though they're 34, all of our help for them will be based on that. They may be able to help with the grocery shopping. They may be able to manage a little bit of it, but they probably don't have an ability to work enough to provide their own income. And they're probably going to need help with anything that's out of the ordinary. And they certainly need someone close by to call at any moment if something doesn't work out quite right for them. And then impaired verbal communications. Some of these children, especially those that are more profound or severe, their ability to speak is going to be quite limited, or they only know some words and not others. So learning from the family when we as nurses need to talk to the children will be beneficial. What words do they know? What do these words or actions mean to them? And sometimes gestures or some sign language has been taught to the children as a way of helping them communicate. So in this case, when we're the nurses, we want to take our cue from the parents. If we're, for example, if the child's been brought to the hospital for an appendectomy or something, we're providing care for them. Let's take our cues from the person who knows them in and out and understands how to interact with them, and pick up from them how best to communicate with this child. Social interactions are going to be a challenge as well. One of the things we really want to teach parents is that we want them to start early, teaching the child to the best of the child's ability to learn, which will vary depending on how severe their intellectual disability is, to do socially acceptable things. This is important because you know how it is when children are small and little. If a 2-year-old does something like throws a little tantrum, we all kind of smile and pick them up and, try to get them under control. Or if the 2-year-old is loud in an area where it is supposed to be quiet, everybody kind of gives the parents the pass card, right? We realize the child doesn't understand yet that this is a quiet place. And the challenge with our children with intellectual disabilities is that if you're 34 and you're still making outbursts in the middle of areas in the movie theater when it's supposed to be quiet, people aren't as forgiving and they'll get negative responses from the public around them. Now remember, most cases are mild, so the child's eventually going to get to a 6th grade level, which means these children are able to learn basic social skills about how to manage themselves in public to be better accepted in public. And we do want to encourage parents to teach these children social skills along the way to help them to be integrated into the public better and received better by other people. Does that make sense, what I'm saying there? Now, some children, if they're profound, they're not going to be capable of learning that. But if they're capable of it, we want to. Go ahead, there was about to be a comment typed. Go ahead and feel free to keep typing. Oh, yes, that does make sense. Great. Thank you, Amy. And so I know a gentleman in our neighborhood that, actually, it's a little girl. I know two people. I was thinking of two people, but this is a little girl, and she's now probably 12 years old and still confined to a wheelchair, doesn't have the ability to control her motor movement very well, and is clearly, probably a year and a half, maybe intellectually. And so, we can't teach her social skills. We can learn what, as a parents and those of us that interact with her, learn how to calm her when she's getting upset. In public, we've learned the tricks of maybe, soothing her by touch, or another child has he really responds well to sponges that have a lot of texture to them. And if you can feel that, and the parents hand him one of those and he starts feeling that, then he focuses on that and seems to be calmed. So family members figure out what calms children, and they carry those things with them, right? So they can keep them calm when they're in public. And sometimes you just have to take the child to a different location because it's just not something they're going to be able to do at this moment in time, to be quiet in the movie theater or to be quiet someplace else. So this will be very individualized, but it's overall, we're trying to maximize their potential, help them be as capable of interacting socially as we can. And then, as I said to begin with, parent education is key, and parent support. Parents kind of go through a grieving process when they discover they have a child that's intellectually disabled. None of us, that's not the dream. And so we have to kind of reset our minds to adjust to the new reality. And most parents do very well with that. And they discover that it is very meaningful, that they love this child, and that they really feel that this is enhancing their lives to have this child in their home. But they need a lot of support, and especially initially as they're getting over the grief. And they need respite, meaning there needs to be respite care where they can have times where they're not fully responsible for the child. So they can go off on a vacation and get on an airplane and do other things they may not be able to do because they have this child, if they're more profound, for example. And so a lot of support is needed for the parents and education for the parents. One thing that's important for parents to understand is if the child is a mild or moderate intellectual disability, as they get older, they have the developmental age of, a sixth grader rather, when they're an adult. Sixth graders don't have the same understanding about appropriateness of sexual behavior. And yet they went through puberty just like all children do at 12 or 13 or 14 years old. So parents need to be aware that their children are going to have those normal feelings, and yet they don't have the intellectual ability to understand consequences. They don't really understand maybe a moral regard regarding this idea. And so parents need to make efforts to make sure the child is safe and that other people don't take advantage of them. We used to take students to camp during the summer that 1 week were the intellectually disability children. And we would always make sure that we let everybody who was working at the camp know that these children were not allowed to go team up and go off together privately, because it would be really bad to send somebody home that was pregnant from camp, right? So it's not something they can process in the same way adults can process. And so it needs to be, the parents need to have that on their radar screen as the child develops physically, so they can take the appropriate actions to keep them safe. Any questions about intellectual disability before we move on to attention deficit hyperactive disorder? Okay, if you do have questions, please chime in and make those. I think I'll take our break right now, our 5-minute break now, because it's such a convenient place to take the break. And then we'll come back and talk about attention deficit hyperactivity disorder. And so we'll come back in just about 5 minutes. Okay, welcome back, everybody. So let's go ahead and start talking about the next neurodevelopmental disorder, which is attention deficit hyperactivity disorder. I'll keep talking, but I really appreciate your comments in the chat. And so this is something that many of you have personal experience with, either because you or a family member or a neighbor or somebody you know has this. If you have a connection to this particular disorder in some way, just put in the chat who it is that you know that has this, a sister, a brother, a child. Just kind of give us an indication if you personally know somebody who has attention deficit hyperactivity disorder and who they are to you. So keep adding those as we talk. So this is a persistent pattern of inattention and or hyperactivity impulsivity that interferes with the function of development. So once again, let's look at this and see that the name tells us what the problem is. Attention deficit, I can't pay attention. And hyperactivity, I'm always on the move, I'm impulsive. And so that is the symptoms of this particular disorder. So a couple of comments before I move into those two components of it. And I'm sure many of the rest of you have people who have this out there. So keep adding who has relatives or relationships who have this particular disorder. I just want to kind of show to the class how very common this is. So please keep including those. So one of the things that's interesting about this disorder is it does seem to have a high genetic component to it. And so this is something that people are born with most often. Occasionally, this will happen secondary to a traumatic brain injury. So if it didn't happen in childhood, it is, for example, possible that you could have a traumatic brain injury as an adult and then develop this particular disorder. But most often, people are born with it. And the two main symptoms are that of inattention and hyperactivity impulsivity. So let's take a look at what inattention looks like. Inattention is just that. People can't pay attention. And I can only imagine how difficult it must be for people with ADHD to try to learn online because there's so little interaction. The ability to keep yourself focused on a screen, especially for very long, could be very challenging. People with ADHD who have inattentive components, which most of them do, find it very hard to go to school in our traditional setting here in the US. Children are expected to go to school, be there at 8:30 in the morning, stay there until 3:30 in the afternoon, a few recesses during the day, but mostly they're expected to sit in their chair and listen to the teacher and follow instructions. And even though they do activities as a group, etc., that can be very difficult for them to focus on and actually pay attention. They lose track of the task they're doing very quickly. They often forget to do things that should be routine for the rest of us, doing their chores, paying their bills, keeping appointments. They have difficulty organizing their lives. Their house and bedroom are a mess. They fail to meet deadlines. They avoid or dislike or reluctant to engage in tasks that require sustained mental effort. And often they're so inattentive that they aren't paying attention when the instructions are given. So then they can't follow the instructions well. They often lose things. They may do the homework, but then they forget to turn it in, or they lose it in their desk, or they left it at home. And so these can be really challenging symptoms for the person. Now, when people have ADHD, they can have primarily an inattentive kind, meaning that's their primary symptom, or they can have primarily a hyperactive impulsive type, or they can have the combination of both. And what research has shown is that everybody has some of both, but they may favor one set of symptoms over another, or some just really have both very much. You can see both symptoms in that individual quite a bit. And actually, that's the most common way it's seen. So people who are hyperactive and impulsive, they fidget, they can't sit still. They often leave their seats at inappropriate times. They're running and climbing in inappropriate situations. They are often unable to play or engage in leisure activities quietly. They're always on the go, talk excessively, blurt out answers in class at inappropriate times, have difficulty waiting their turn, interrupt others or break into other people's conversations or games. And these hyperactivity impulsive behaviors have a tendency to bring attention to the child. Someone who favors inattentive can go under the radar screen, may not be recognized as early as having this, because if they sit quietly in the classroom, they're not disturbing the teacher. So they may not be digesting or hearing anything the teacher says, but they're not bringing attention to themselves, so it may go unnoticed. Those whose primary symptoms are hyperactivity and impulsivity, everybody notices. Teachers notices, the parents notice, the peers notice, the siblings notice, because they're bringing attention to themselves by their inability to sit still and by their impulsive words and actions. So you can see this can just be a really frustrating event for kids today. Now it's interesting, we actually don't think the level of ADHD is higher today than it was in the past. But we do think our social norms make this more apparent. So consider, if you were born in the 1800s and the typical life for a child or person who has symptoms of ADHD was to get up in the morning, go milk the cows, take care of the chickens, run around the farm, expending energy, chopping down trees, et cetera, you could see that that lifestyle kind of naturally flowed better with somebody with ADHD. They would still have been more accident prone. They would still do some impulsive decisions that would have been challenging, but they wouldn't have been expected to sit still in school 5 days a week for hours on end, or go to work and sit still at work and complete tasks and get them in on time. So our lifestyle today is very different than it was 100 years ago. And we think that's why ADHD is more on the radar screen today than in the past. So children with ADHD have to have, in order to get a diagnosis, they have to have problems both at school and at home. This is important because a lot of children have a lot of energy. A lot of children, have a hard time sitting still or get bored and want to do something else. Children who are very intelligent can get bored very easily. They don't have ADHD, they're just bored and, start picking at their neighbor because they're bored. So the important thing to remember is that this diagnosis should not be made unless the symptoms uniformly appear in all aspects of the person's life. And since this is typically diagnosed in childhood, those two aspects are school and home. So let's take a look at what it looks like for somebody at school who has ADHD. So first of all, there's going to be challenges between the teacher and the child. Because if you are teaching 24, 28 children in a classroom, possibly more here in Utah, you only need maybe 2 or 3 children with ADHD in the classroom who can't sit still, who are poking their neighbors, who are passing notes, who are whispering, who are chuckling, or who are inattentively looking out the window and failing to follow the instructions, so you have to repeat the instructions 2 or 3 times. And you can see that this can become very disruptive in the classroom and frustrating to the teacher. So teachers are often aware of who in their classroom is struggling with this. Their academic performance is very uneven. If a child is interested in what's going on, they can focus. There's nothing wrong with their intellectual ability. Matter of fact, some of these children are very smart, but their motivation to stay engaged with the task may wane before they've completed the task, or they have no interest in it, so they just don't pay attention to it. And they get distracted and start doing other things in the classroom that bring attention to them and is disruptive to classmates. They may do their homework, but then forget to bring it to school and turn it in. They sometimes do well on tests and other times they don't. They have great difficulty following the ground rules because sometimes they're not really listening to the rules, or they are so impulsive that they know the rules, but they can't sit still long enough to kind of follow the rules. And so this can be really difficult and challenging for parents who are perplexed. He seems to do so well sometimes, and then other times he's failing. Why is that? And this unevenness has more to do with the child's style of attentiveness and impulsivity than it does their intellectual ability. They are often very smart. Intellectual ability, so I've kind of gotten ahead of myself there, talking about their performance on tests reflects their attention and desire to understand the information. And their motivation may be low, which leads to them not being as successful. And by the third or fourth grade, they may feel poorly motivated because they keep running into failure. And they don't quite understand why they're failing, because their hyperactivity and impulsivity is second nature to them. They don't actually see how it's creating problems around them. And their inattentive and distractibility causes a lot of disruption with peers and in getting classwork done, etc. So these listed problems that exist in the school are the things that they're going to be looking at. When a pediatrician or a specialist is asked to evaluate a child for ADHD, they should be sending a form to the school and to the teacher that collects information about how this child performs at school and what the teacher is experiencing. And then they're going to have the parents do the same thing. And I guess I haven't quite finished the social school one here. Let's just back up and say that they are having struggles socially as well, because they draw so much attention to themselves and they're so impulsive that they can get their neighbors and friends in trouble. The friends don't appreciate that, or they can become very bossy and annoying, teasing, interrupting, and that can sometimes cause them to not have good social relationships. Consequently, they get a lot of negativity from everybody, really, from the teacher, sometimes from peers, from their siblings, from their parents, and there can be a lot of negativity comes their way because they're just not following the rules of society and the social norms as people expect them to do. And that can bring up a lot of negativity. One of the tricks that we try to teach parents is if they are having a struggle with their peers, and usually it's those who tend to have hyperactivity and impulsivity as their main symptom, who are having problems with peers, then one thing that works well is to invite friends over one at a time. If you invite a whole group of friends to the home, then the friends tend to hang out with each other and leave out the child who has the ADHD. However, if it's, for example, a birthday party and they're inviting one special friend from school, well, that friend has no one else to interact with but the child who has the ADHD, and that helps them to interact because the child probably will accept the invitation, will interact with that friend, and the interaction will be more successful because it's one-on-one as opposed to potentially being left out of the group when there are more children present. So that sometimes can be helpful if that's happening to a child. So the second part we said was it has to happen at school and it has to happen at home. So what do the parents see? What do the siblings see? Well, they're going to have problems at home in the same way they have at school. They are impulsive, they're constantly moving, they're disruptive, and the parents are often perplexed because the same things they did for other children to help them learn to, kind of proper behavior and to be prepared with their homework and to study, and the routines they've set up in their home that have worked with other children don't seem to work with these children. And it's very perplexing and frustrating to the parents. So as we go through these next slides, I'm not going to read them because they're in front of you. Instead, I'm going to tell you a kind of a scenario that's common for children in the home with ADHD. So hopefully you can kind of relate to this scenario. And when we come to talking about the interventions, which I'm also going to integrate, then you can see how they go hand in hand. So the child, as I stated, the pediatrician has to see problems in the home and in the school before the diagnosis is made. This is critical because parents sometimes, and sometimes teachers, but more often parents, don't always know what is normal for a child. And so it might be a temperament difference. For example, if a parent maybe is 38 years old and has a 2-year-old running or a 4-year-old running around the house, and that child has a ton of energy and is into a lot of things and discovering a lot of things, they may in fact believe that their child is hyperactive, when in reality they're just a normal 2-4-year-old. And because the parent's running out of energy to keep up with that young person, they may perceive it a problem, when in reality it's just normal development and growth. So we don't want to call normal growth and development abnormal. And so that's why we need to see it in both places. Because sometimes parents perceive a problem that's really just normal growth and development. And in which case we need to teach them about normal growth and development and teach them ways that they can interact with that very intense or very involved child where they feel more successful and don't feel so frustrated with the child. If it's happening in both places, these are the things we're going to see. Now, for those of you, I don't see anyone here who's claiming that their child has ADHD. Yes, exactly. Thank you for sharing that, Jessica, because children wear you out. They've got far more energy than us. I think there's something wrong with that whole paradigm. Parents are the ones that should have more energy, not the children, but it isn't that way. And so it is tempting for parents to claim ADHD for perfectly normal, active children. And so that's an important consideration. We don't want to call something abnormal when it's not. Now, if you did have a child with ADHD in the home, this would be a typical scenario that would happen. Transition times are really rough with any child, but especially children who have ADHD. These children are impulsive, they're unaware of time, and they're inattentive to instructions. So let's suppose you're a nursing student, you have a child with ADHD, and you've got 3 kids to get out to school this morning before your test. So it's already a high pressured morning, or you're working and there's a big meeting at work, you've got to get there. And so you get the children up, you tell them to get down for breakfast, you've made breakfast, you've got their lunches ready, and you're about to head out the door. Now, if one of those children has ADHD, a very common thing to happen is they get up, they get in the shower, and they're oblivious to time. They're in the shower, they're enjoying the warm water, and it never occurs to them that they should get on a move on until mom starts yelling at them through the door, or they use all the hot water and now it's cold and they decide to get out of the shower. When they come down the stairs, they're already late because they've taken too much time trying to get ready because their mind is elsewhere. They're not really feeling pressured about getting out the door. They're not paying attention to the clock and what needs to happen. And so they come down, moms say, get your breakfast, we're running late, put that on a paper plate and eat in the car. And we all dash out the door only to get in the car and realize that little Johnny has left their homework upstairs in the bedroom. Go get your homework. The whole family's waiting. Everybody's feeling tense. They come back with their homework and they get to school only to discover, oh shoot, you left your lunch on the counter. Here's some money, buy some at the cafeteria. We're on our way. Then later the parents receive notice that, that homework we helped them with last night never got turned in. And now the child's getting a 0 on assignments the parent knows perfectly well they helped the child accomplish. So what happened there? I saw them take their homework to school. How come they're not getting the grades right? So this constant frustration is part of having a child with ADHD. And parents can become very distressed trying to figure out how to help this child. And so as you look at some of these symptoms, realize that the child themselves is lacking awareness of the trouble they're creating. They don't actually see themselves as the person with the problem. They don't realize they're rocking, humming, that they're taking forever in the shower, that they're slowing everybody up. But they're feeling the negativity when people are on their case about it. And so it's really challenging for them. Their impulsivity makes it hard for them to follow rules in the house. And sometimes it's a natural tendency for parents to just, add to the punishment. if you make us late tomorrow, then you can't ever go out and play, then you're not going to be able to be on the football team that you value so much, this kind of thing. Unfortunately, that doesn't work. The child isn't intentionally trying to foul the world up. And so trying to punish them more doesn't actually lead to the outcome parents want. And this is a little sidebar that we try to teach parents. There should be consequences for the child with ADHD that are reasonable and appropriate. But we don't want for any child, but especially the child with ADHD who's getting a lot of negativity, we don't want to take away their lifeline that they're doing well in. So for example, let's suppose the child is on the soccer team. They love it. They're good at it. They're successful with their peers there because they're part of the team and the team values them because they're good at it. It would be very unwise for the parent to put soccer on the line as a punishment, because inevitably this child's going to have times when they're not successful because of that impulsivity that they don't have a great awareness of. So if we say, fine, we're not going to let you go to the soccer practice this afternoon. That's your punishment. Well, now you're taking away the few things that they're successful in life with. So if a child's very successful at something, choose a different punishment. Choose something that will have meaning to them, but doesn't interfere with the things they're being very successful at. Does that make sense to people? Instead, for example, we might limit the amount of time they get to play games, their computer games or something, rather than something that's really bringing success and positiveness in life, like the soccer team. Does that make sense? Give me a heads up. I wish I could see you to see if what I'm saying is making sense. Okay, very good. Thank you. Okay, so the problems at home can continue. It's not just the parents who are struggling with the child and trying to keep them in the routine, trying to keep them on task, trying to help them be successful at school, trying to help them do the chores around the home they're supposed to be doing. But the negativity can extend to the siblings. Siblings pick up on what parents do. You may notice this if you're a parent, or you may have had this dynamics in your own home growing up, that if mom and dad are on little Johnny's case about always being late, well, sure enough, then older sister or younger brother starts getting on Johnny's case for always, you're making me late. You're going to make us late again. So everybody's getting in on the act. Or the siblings might feel embarrassed about Johnny. They go to school, they see that Johnny disrupts classes, that Johnny is annoying people out on the playground, and they're embarrassed about their siblings. So this can bring out frustrations and difficulties between the sibling and the child. So you can see the challenges. Let's talk about what some of the treatments and solutions are for a child who has ADHD. The good news is we have very valuable things we can do for these children. Let's talk about pharmacology first, and then we're going to talk about the things we can educate parents to help them help their children. And that's actually, for this disorder, the biggest, most powerful key. Pharmacology is very valuable to children with severe ADHD and moderate ADHD. Sometimes, if it's mild, parents prefer to try just the lifestyle intervention stuff first and avoid the medication. And that's okay to give it a trial run to see if that will work. But if it's a really severe case, they're probably going to need the meds along with the lifestyle interventions that we're going to talk about in a minute. So let's talk about the medications. We give children with ADHD, interestingly enough, CNS stimulants, central nervous system stimulants. Well, on the surface, that doesn't make any sense at all. I've just been telling you how hyperactive and impulsive this child is. Why in the world would I give him a stimulant? That seems like just the opposite of what you'd want to do. But this is the very interesting thing. Central nervous system stimulants actually make it possible for the child to focus their attention and concentrate longer. on tasks. And in that way, it helps control their hyperactivity and limits their impulsivity, or it helps it to not be as bad. So it's kind of, an odd thing that it helps, but they have done studies to demonstrate that it truly does help. For example, they've given math tests to children who have been diagnosed appropriately for ADHD. And these children not on meds are given a grade level appropriate math test, and they see how they do. They get their score. And then they've given them short-acting central nervous system stimulants. And after a couple of hours, they give them a same level equivalent math test. It isn't the same numbers, but equivalent math test. And they see a dramatic improvement on the child's grade, because these drugs help them to focus and keep their attention on a task long enough to be successful. Remember, we've always said it wasn't intellectual disability. Matter of fact, many of these people are very smart. It's their ability to pay attention and stick with the task long enough to show it that is challenged. So these medications work very well. There's a couple of things we need to know about them that are important when educating children and parents about these meds. And I haven't said this yet, but it is true that if a child has ADHD as a child, they don't typically outgrow it. People have ADHD throughout their life. Now, the signs and symptoms look a little bit different. You can see that as they get older, they have a little more control in their lives, right? So they sometimes benefit by choosing careers that allow them to be more active, as opposed to having to sit and do something really tedious all day that they don't have any interest in. So allowing them to choose a profession that they're interested in and that allows them to, if it's important for them, to be more physically active can be beneficial to them and help them be more successful as an adult. So adults may need to be on these meds as well, is what I'm saying. The names of these meds are Ritalin, Concerta, Dexedrine, Adderall. So you recognize many of these. And they come as short-acting meds and long-acting meds. We want the medication to peak throughout the times we want performance. So oftentimes these medications are given in the morning so that it will help the child throughout the school day or the adult throughout the work day. But because they're a stimulant, we want them to kind of wear off at night so it doesn't interfere with their ability to sleep. Notice that some of the side effects, the first side effect listed is insomnia. It's like you all know that caffeine is a central nervous system stimulant. We take it in the morning so we can wake up. And if we're sensitive to it, we're told not to take it after noon because it might interfere with our ability to sleep at night. So it's the same kind of concept. We want it early in the day to help you with what you need to do, but not late in the evening where it might keep you up at night. Loss of appetite and weight loss can happen with this. So children, this is an important thing to keep track of. You need to make sure that they're gaining the appropriate weight, that they're eating nutritious meals, that they eat a good breakfast in the morning, and that you send them with snacks throughout the day so that they can continue to eat through the day and keep their calorie intake up. One of the challenges with children is that they're on a growth curve and we're giving them a medication that might cause them to lose weight. So that could be a problem. So we're going to watch that very carefully and try to make sure that they don't fall off the appropriate weight gaining trajectory. Having said that, can you see these drugs might be tempting to be used by people for whom they're not prescribed? I don't know about you, but I would love it if I could eat all the chocolate I wanted and not gain weight, or I had more energy than I seem to. I don't know about you. I don't get enough sleep like many of you, and sometimes it can just really feel like you're dragging through the day. So can you see that these drugs might be diverted to somebody for whom they were not prescribed? Unfortunately, sometimes that diversion goes to the mother who desires the weight loss and desires the extra energy. If a child is at college, sometimes the diversion goes to roommates because college students sometimes falsely perceive that if they take the Adderall, they'll do better on their exams. The interesting thing is that if you don't have ADHD and you take these drugs, all they do is make you anxious and jittery. They don't actually help you concentrate more because you didn't have the deficit that needed to be corrected to begin with. And so diversion of this drug is an important concern. Doctors will therefore, because they know these drugs can be diverted, they usually prefer to give the long-acting drugs because long-acting drugs don't have as profound and effective waking you up in the morning like you would get from a cup of coffee, for example, because it takes too long for that to come on. Overall, it helps, but it doesn't give you that boost. And so they're less likely to be diverted if they're long-acting drugs. So doctors favor giving the long-acting drugs. And second, especially when the child is in college or if the doctor has any suspicion that diversion might occur, they make it very clear to the adult patient that I'm going to fill this once a month. You get to have your appropriate dose for once a month. If you lose them, if anything happens to them, you just have to live until your next prescription comes out. So keep these under lock and key while you're at college so nobody steals them from you, because even if it's not your fault, they're not getting re-prescribed faster than this. So these are some of the things the doctors do to try to prevent these drugs from being diverted. Does that make sense to you that this is a concern and that we need to pay attention to that? Okay, there is another group called selective norepinephrine reuptake inhibitors. Remember, those were typically antidepressant drugs, but this particular one, Strattera, is used for ADHD. It too has decreased appetite, nausea, vomiting, tiredness, and upset stomach as possible side effects. So we need to give it with food, eat a good breakfast, substantial nutritious snacks, use calorie-free beverages because it can cause a dry mouth, and then they monitor for liver function tests when people are on this particular drug. It seems to work very well for ADHD as well. So that was the one arm of treatment, right? Medications. I, however, said a moment ago that the second arm for ADHD is very, very important for everyone with ADHD, whether it's mild, moderate, or severe. So let's take a look at what that looks like now. The very first and most important principle for interacting with a child with ADHD is to be positive. And as I started this presentation, I said that if you want to make a difference with children, you have to teach the parents how to do things differently in the home. So these comments for interaction are really going to be pointed towards what to tell the parent on how to help their child with ADHD. So instead of telling the child what not to do, you want to tell them what you expect. Instead of saying, Johnny, quit hitting your sister, you say, Johnny, please keep your hands to yourself. So always put it in the behavior you want to see in the positive light instead of the negative. They've actually done studies in children with ADHD, interestingly enough, kind of sadly, in our society, all children get a lot of negatives. Think about it. If you're a parent, kind of start noticing how often you tell your child not to do something. So all children receive a certain amount of negativity as they grow up, as we try to train them and to teach them. But children with ADHD get an extra portion of negativity, and that can lead to longer term problems, which we'll talk about next week. So the whole focus of interaction is we want that interactions in the home to be more positive than they have been in the past, and for the child to feel a more positive way of learning the right ways to do things. Restructure your expectations of the child. Don't punish them for things that are beyond their control. Some things are just a matter of style. So for example, if a child has ADHD and they just can't sit still, first of all, punishing them won't help them feel like they can sit still more. And as long as it's not disruptive, is there really any reason to be worried about it? Give the medications a chance to work, give time a chance to work, and just practice going, this one's not important. This one's not something I need to worry about. Sometimes you'll notice at school, for those of you that have children with this, that the teachers have ways of helping the child with this. They have pillows the child can sit on, which allows them kind of move around in their seat, but stay in their seat. So you get the better behavior of them staying put, but it meets their need of needing to move. So looking for those kinds of interventions that kind of allow them to do what they need to do, but also help get the behavior that's really important to us, sitting in your seat when we need you to, is always a good idea. Often kind of illustrating to the parent that, if your child had a visual problem, you wouldn't get mad at them or try to punish them for that. You would buy them reading glasses. So it's important for us to think about that. Since some of these behaviors are second nature to them, not really something they can control well, what can we do to help those behaviors be managed in a way that makes it more acceptable to us, more acceptable to the school, more acceptable, so that the child's style can be okay? And interaction successfully. So set up specific time periods for waking and chores. Have rules, be consistent, and don't be afraid to have consequences. So I'm going to give you a little scenario about what this would look like. Remember, we talked about transitions earlier and how hard those are on families with children with ADHD. Let's see how we could do that differently if we were the parent, the things we would teach them. So we know mornings are rough. There's a lot of pressure to get out the door on time, a lot of consequences to the parents and other children if we don't get out the door on time. So in order to solve that, we would actually start the night ahead when things are calm. We're going to interact with the child and we're going to help them find their homework and get it into their file in their, whatever package or bag they're carrying their homework in. And we may need to help the child be more organized. We may need a slot for math, English, science, whatever their classes are. And we're going to put the homework in the correct slot. We're going to help them succeed in that, because remember, these children can't organize themselves well. So we're going to help them be organized. And then it's going to be laid out and ready the night before. We may need to lay out the clothes they're going to wear on the chair or someplace the night before, so they're ready to go. It's very wise, when the child can read, to actually have a checklist of the morning routine. Even though they do the same thing every morning, that checklist is helpful for them, because then they can check it off and see they're being successful. They're meeting the parent's expectation. So you get up, you go into the bathroom, you use the bathroom, you come down, you eat breakfast, you go up, you get dressed, you pick up your homework, you brush your teeth, you come down, you pick up your lunch on the way out the door. So whatever the list may be for your family, it'll be very individualized from family to family. But if that list is in their bedroom or in the bathroom or in a visual place where the child can see it, or if they're not succeeding, the parent can say, what's next on the list, to remind them of the routine and allow them to be successful. So use whatever works for them to help them follow the routine. Have a routine. Routine is very important for all children, but especially for children with ADHD. And then reinforce it. Some children's ADHD is so severe that they might start the list, but then they got sidetracked off of it. So for example, again, they get in the shower. They have no sense of time. So they aren't getting out in time for everything else to get done before getting out of the house on time. So things like setting a timer so that it dings after 5 minutes. And if they've got shampoo in their hair, that ding reminds them they've got to hurry up and get out of that shower. As opposed to mom having to yell through the door, what's wrong with you? Why aren't you getting your act together? You're going to make us late. Kind of negativity again. Just build into the routine things that help this child be successful at doing the routine. That can be very individualized and look very different from person to person and family to family. There are no absolute rights and wrongs, but you get the overall idea. Have a routine and do whatever necessary to help this child successfully meet those expectations. That way, mornings are not as hectic, they're not as confusing, there isn't as much pressure on everybody. If I'm not as pressured as the mom, then I don't feel inclined to lose my patience with the child as much, and everything is more positive. What are some things you guys have seen used with children who have ADHD that have helped them have successful ends to their interactions, either at home or in the family? So at moments like this, I'm always like, anyone? Anyone? I feel like Ferris Bueller. Thank you. Definitely the routine. Do you guys have some specifics that you've seen teachers use or parents use? While you're typing, feel free to type in as I give you some other hints of things I've seen. For example, helping a child do homework, letting them do it in smaller sections because they have a hard time concentrating for a long time, and making sure that they do their homework in an area that they're not easily distracted. So they should be in part of the house where they can't hear the TV in the other room, that type of thing. Anything else that you guys are aware of that you've seen? Feel free to type while I'm talking. Everybody can benefit from what you're saying. Okay, break the tasks into smaller parts, give instructions one at a time, praise them frequently for their success. And this was the homework one that we talked about. And don't be afraid to set limits on the child. We do expect this child to recognize the difference between right and wrong. We do expect them to have consequences when they aren't doing what's right. However, the consequences need to be appropriate for what's going on with this child and not excessive. And if you can find a way around being punishing and instead find a way to encourage success, that's going to help decrease that negativity, which can be so hard on these children. And these are some additional comments about how to help children and siblings with ADHD. Now, the important thing to remember about all of these interactions, and I'm not going to read them all to you because you're capable of reading, but this list that I presented to you is very specific, and it actually came from the school districts, not from your nursing manual. Because this is what nurses and healthcare providers will be reinforcing to teachers and to children. Teachers are usually quite well versed in this because this is part of their education. The parents whom we interact with may need these ideas and suggestions, and they so much want them, right? They don't like being frustrated with their child. They don't like things going poorly in the morning. They feel bad when they lose their patience with their child. So teaching them ways to interact better and more successfully is typically very embraced and very desired on the part of the parent, and they'll be so grateful to you for this. So a testing hint. This slide presentation on ADHD with all the specific things you need to recognize for signs and symptoms and the specific things for interventions are the take-home message, more than the reading from the textbook. Any questions about ADHD? Okay, another good break time for us. So let's go ahead and take our break. Okay, welcome back, everybody. So our third component of what we're going to talk about is autism spectrum disorders. So autism spectrum disorders is an interesting disorder that typically begins in childhood and often is recognized when a child is 2 and 3 years old, sometimes earlier. With this, the word autism means that a person is within themselves, that they're within their own little world. Now, this is not the same as being psychotic. Remember, psychotic people are out of touch with reality. These children just are within their own world, the world of their making. And they often have great difficulty with social relationships, communication, imaginative activities, and they often have very restricted activities and interests. The onset is typically before the age of 3, although there are occasions where something can happen later in childhood and then they develop it. That's pretty rare. Most often this is something that happens very early in childhood and gets discovered around the age of 2 and 3. Parents start noticing the child isn't interacting in the same way as other children. Sometimes they can tell that even earlier. It's 4 to 5 times more prevalent in boys, and there tends to be a strong genetic component, and it tends to be chronic, meaning that they'll have it throughout their life. So let's take a look at each of the categories of symptoms. And let me just start by saying autism is on a spectrum, meaning that they can be mild, moderate, or severe. Sometimes autism is a comorbidity with intellectual disability. So let me just say that again. Sometimes autism is a comorbidity with intellectual disability. So they have both autism and they're not developing intellectually like they should, the first disorder we talked about. Sometimes autism is by itself, and often it's by itself, without an intellectual disability. So you may see it both ways. When I talk about it on the test, I'm talking about it on its own, unless I talk about the comorbidity of intellectual disability. That's how it would be described. It would be both would be in the description of the child's problems if they've got both. If they're just talking about autism, that's all that's meant. And they mean, again, that mild, moderate, or severe. Now, one of the big categories where they have impairment is social interactions. And this can start early. Parents will sometimes, moms will sometimes start noticing that the child is just not affectionate in the same way her other children were, or in the way they expect children to be. They don't necessarily want the hugs. They may not give the eye contact. They have an aversion to touching others or being around others. As they develop, they don't go through those developmental stages of the way children learn to play with one another. And they don't develop cooperative play or imaginative play. And this interferes with their ability to make friends. And so they show very little interest in responding to others. They really are in their own world. Something dramatic might be going on in the room and they're just not interacting as a normal child would. You know how many children are very sensitive what's going on around them. If you've ever cared for a group of children together and they're small children and parents bring in a child and one starts crying, others that were perfectly fine a moment ago notice the child that's crying and start feeling unsettled and may start crying themselves. So most children are kind of attuned to one another, even at very early ages. These children are not, because they're in their own little world. Impairment in communication. So they have a delay or a total lack of spoken language. Now, a delay in learning language by itself does not mean the child has autism. They have to have symptoms related to all of these areas in order to be on the autism spectrum. And this is one that sometimes is misunderstood by parents, or they become concerned unnecessarily if there's a delay in developing communication skills. Children just learn to communicate at different times. So for example, I have, again, a niece that has a number of children in her home. When she had her recent little baby that was growing up, it just didn't learn to talk and was getting quite a bit older and just didn't say very many words. And then another baby was born, and this child immediately learned to talk. And it was because when she was the baby in the house, everybody just kind of met her needs. They paid attention to her. She didn't have to talk to get what she wanted. And then when there was another baby in the home and she was getting less attention, if she wanted something, she had to speak up and ask for it. So it wasn't really that she had any problems with it. She just wasn't motivated to learn to speak or to talk a lot at an earlier age. So things like that can happen to cause a delay in speaking. Sometimes a delay in speaking is related to being hard of hearing. The child can't hear well, and so they're not picking up their language skills. So remember when we talked about at the beginning of the semester that you can't take just one symptom and think it is proof of a specific diagnosis. You have to have a lot of symptoms that fit into a pattern before diagnosis can be made. So that's my hint here, is that with verbal communication, before you decide it's connected with autism, make sure that we've ruled out other possible reasons for a delay in learning to communicate as well. Eye contact and facial expressions can be avoided. And they may have idiosyncrasies whose meanings aren't clear to those who aren't familiar with the child. And they can use repetitive words and phrases. So early signs of impaired communication include that they're not babbling or pointing by 1 year of age. And by 16 months, they don't have any words. And by 2 years, they don't have phrases. Now, most children, even if something else is going on, will normalize by the age of 4. But if they don't normalize by that age, that really favors that they may be autistic. If we haven't discovered, for example, that they're deaf or something. Normal children may have these language delays, but children with autism not only can't speak, but they lack comprehension. So that is key. So a child who's deaf may not be able to speak, but they usually can figure out their world and can comprehend what's going on around them with gestures and other kinds of communication. Children with autism also have restricted activities of interest, so that they're very regimented. And children, again, don't hesitate to put your experiences and comments into the chat box. I think everyone likes to hear and see those. Of what kinds of specific kinds of restricted activities you've seen with children who have autism. And things that can really upset them can be just so minor. If the child is setting up blocks, many children set up blocks, but children with autism often set up the blocks the same exact way every day. And if somebody comes around and changes the order, or another child comes over and kicks it and causes the blocks to go tumbling down, these children have a major meltdown. They cannot handle a change in their routine. Transitions for them are extremely hard, and they are very regimented in their views of the world and what's got to happen within their own little world. So even minor changes can cause hysterical responses. They have become extremely attached and interested in specific objects. So for example, they might be watching spinning fans, or they're very aware of the noises in the room. It's interesting, until I started teaching online, I didn't realize my office was so noisy. I'm right next to one of the rooms that has things like the heater system in it and that kind of thing. And I didn't notice until I was teaching online all the noise that I can hear every day, because most of us block that kind of thing out. The children with autism sometimes are hypersensitive to noises and sounds and things in their environment. And so that can be a real challenge for them as well. They have inflexibility and to rules. They might have ritualistic things that they'll eat. For example, one of my neighbors has an adult child with severe autism. And he's a big man, because the only thing he'll eat is pizza, cheese pizza from Caesar's Pizza. Can't be Domino's pizza, can't be pepperoni pizza. And he has a few other things he'll eat as well. But he'll only eat very specific things, and there's no talking him out of it. There's no helping them to expand it very readily. That can be a real limitation and be a challenge for their nutrition. They become very anxious, and they can do things like self-injurious behaviors because of their inability to communicate well or to be understood by others. And so sometimes they'll do things like bang their head on the floor, or bite their arms, or hurt themselves in some way. So if a child has severe autism and that self-injury is some of their behavior, then we do things that protect them. You may have seen children who wear helmets because they're headbangers. And since we can't seem to get them to not bang their head, we protect their head until they grow out of that, or we're able to get them that behavior more managed better. And they can have very restricted and stereotypical movements. So things that are like they might be picking at something all the time, or stereotypical movements are things like um, uh, drumming your fingers or something like that. I'm just noticing that some additional comments have been made. My cousin has severe autism and has to eat certain colored foods on certain days. That's an interesting one. I haven't heard of that one. That's great. Thanks for sharing that. My brother that has autism has really bad texture issues. He isn't able to eat anything with potatoes because he can't stand the texture of them. Very excellent point too. Texture does play a big role. They seem like they're hypersensitive to the environment and things, again, that we don't notice. They may be very attuned to things like texture. Thanks for sharing those. Other restricted activities or stereotypic activities that we might see is hand clapping, hand flapping, toe walking, rocking, whole body swaying, stacking objects, and very upset if the stack is changed in a way, or lining up objects and being upset if anything changes. So this is really a challenging situation. And again, depending on if they're mild, moderate, or severe, depends on the level that these kinds of activities interfere in their life. So when we're completed here, you're going to have two learning activities. One is going to be watching a film on Temple Grandin and talking about the signs and symptoms that she expresses of having these classic symptoms of autism. Now, Temple Grandin is a true person, and this is a film made by HBO. So I'm going to actually have you watch a little bit longer segment of it. I think it's about 25 minutes worth of it, but it's done by HBO, and the actress has really captured the real Temple Grandin. You know how they have commentaries along with the film? If you have this film, you can listen to the real Temple Grandin commenting on the film that's been made about her. And she's an amazing woman. She's actually gotten her PhD and has done amazing things in her field of study, which is animal husbandry. She's somebody who's come up with a revolutionary way of slaughtering cattle so the cattle don't become upset before that happens. And so her story is truly amazing. And one thing I want you to notice when you're watching the film is that Temple Grandin is very smart. So she clearly does not have any intellectual disability. She does not have the comorbidity of intellectual disability. But she is living in her own little world. And the film really kind of, I think, brings to life these symptoms we're talking about. I really like it for that reason. Most students really enjoy this film, so I hope you will as well. There's a worksheet that goes along with this film, so download that worksheet and be filling it out while you watch the film. Children with autism are in their own little world, and they really are missing the social cues around them. They really don't get it. It's interesting in the commentary, Temple Grandin is now, I think, probably in her 70s or something. And she commented that she was in her 50s before she realized that what it meant when people rolled their eyes at her. She said, I'm kind of glad I didn't figure it out earlier in life, because people rolled their eyes at me all the time, because she wasn't meeting social cues, and she just couldn't figure out other people and how they thought, and would say and do things that made people, roll their eyes at her. And she didn't have a good sense of personal hygiene, because she was just so focused on the things she had interest in, to the exception of everything else in the world. So I hope you'll find that learning activity helpful in reinforcing these signs and symptoms of what it's like to have autism. So the nursing interventions for autism are also represented in the film, and I want you to pay attention to that as well. As we said earlier today, and always, if it's a psych problem, what's the highest priority? If you're asked a priority question on the test, somebody type it in for me. Safety, safety, safety. So good. I'm glad we've got that message across. So for a child with autism, they are at risk for self-injury, as we mentioned a moment ago. And so we need to work with these children on a one-on-one basis to try to figure out what's triggering the self-harm. If we can control the environment so that they don't feel the frustration that leads to the self-harm, then we can sometimes prevent that behavior. And that would be very important. Meanwhile, while we're trying to figure it out, or if they have impulsiveness as part of their behavior, we would do things like helmets, padded hand mitts, or arm covers to keep them safe until we're able to find ways to manage that behavior so they don't become frustrated and hurt themselves. Social impairment's a big deal. And so when we're a nurse, it's very important that we have congruency of care. So, for example, if they're brought into the hospital for an appendicitis or something of that nature, we'd want to assign the same people for every shift while they were caring so they could build a rapport with that person. A lot of changes is going to be very upsetting and distressing to people with autism. Ensure the warmth, acceptance, and ability are conveyed. Provide them with objects, blankets, toys, whatever they need to feel safe and secure. Be positive with them and learn from the parents what's going to help calm this child. Parents know their children best, whether that child has intellectual disability, ADHD, autism. I can't emphasize enough to you how important it is to listen to parents. They have lived and learned what works best for soothing their children. There's no reason for us to go through that learning curve. Just listen to the parents and reinforce what's working that's safe and effective. Impaired verbal communication, again, that consistency and giving positive feedback. Recognizing that eye contact and nonverbal communication may not be well understood by them. Parents should be taught, like we teach the child with intellectual disability, to teach proper social behavior to these children early and reinforce it. When you watch the film on Temple Grandin, you're going to notice that her mother, interestingly enough, she was diagnosed in the 1950s, I believe it was. And in the 1950s, if you can imagine how awful this would be, but because of Freud's belief that everything bad that happens to an adult is because their mother did something wrong, that was a common philosophy viewed by the psychiatric community. And Temple Grandin's mother was actually told that her autism was her fault. Can you imagine how awful that would be? We know that that's simply not true. Autism seems to have a genetic link, and it is not the fault of the parent. And we need to be there to support the parent so that they can manage this in the best possible way. Temple Grandin had an amazing mother that, in spite of all odds and no direction from anyone, did many, many things right for her. And that's why Temple Grandin was so successful in spite of her severe autism. So one thing I want you to notice in the film is that there's a little clip where the mother is told that Temple Grandin as a child has autism, and they call it infantile schizophrenia. I just want to clarify now that that is not schizophrenia we've been talking about last week and on today's test. Infantile schizophrenia is an old name for autism. So don't think that there's some connection, because there is none. It's simply an old name used in the 1950s and before for what we call autism today. Disturbed personal identity. Help the child to separate themselves during self-care activities such as dressing and feeding. Assist them with learning their own names and body parts. Use mirrors and drawings to help them see themselves and how they're different from their mother, and start to learn about their environment and what things. One of the things that Temple Grandin's aunt does for her that's depicted in the film is Temple doesn't get emotions. She doesn't get other people's emotions, and she doesn't get her own emotions. And so her aunt does some interventions that are very effective to help her figure out emotions, because it's not an innate thing for somebody with autism. So you can watch for that as well. Okay, so Couple of learning activities today. First of all, if you have any questions about anything or about autism, please type it into the chat right now while I'm kind of summarizing, and I'll be happy to answer those questions before we leave. So a couple of things. You have two learning activities today. You have learning activity 13 and learning activity 14. They're both due by midnight, and they're both about to open in 5 minutes at 11 a.m. So if you just take a bathroom break and come back, they will be open. I do try to provide class time for my learning activities, because if you were in the classroom with me, we would have done them during class. And that's why I have them do the day of class, to try to keep everybody current in the class, and so that they aren't forgotten throughout the week as you get sidetracked with other things. So please be aware that they'll both open at 11, that learning activity 14 is a worksheet that you fill out while watching the Temple Grandin film. The Temple Grandin film is a big film, so it's separate in the modules under the neurodevelopmental module. So you'll see it right there, just like you saw the one that we did the other week. Okay, and I've enjoyed reading your discussions on the Voices Lab. And I've read all of them from yesterday. I'm about to read the ones, from Monday. I'm about to read the ones from the group from yesterday on Tuesday. But I hope it was an insightful experience for you. And most of all, I hope you feel compassion for our people who are out of touch with reality. I can't even imagine how hard it must be in life to not be able to trust your own thoughts and what you hear and think. That's got to be such a disconcerting and vulnerable feeling. And so I hope that this learning activity was really insightful for you and beneficial to you. Any questions before I sign off? Okay, good luck with everything you're doing. I know you've got a lot on your plate. This week has been especially busy, but we're getting down there. Only a few more weeks, and then and you'll be done with the semester. Congratulations, you guys are doing great. I really appreciate you all. And don't hesitate, once again, to reach out to me for any questions you may have on the test or anything else in the class, or while you're studying for the test. I really appreciate the feedback you give me. That helps me respond to what your needs may be. Thanks.